What is the diagnosis? A. Pericardial cyst. B. Right atrial enlargement. C. Aortic aneurysm. D. Mediastinal mass. Correct answer C. Aortic aneurysm. Other conditions do come in the differential diagnosis of a similar appearance. In this case, previous X-rays were available to support the diagnosis. Asymmetric VSD closure device has been designed for the closure of A. Subpulmonic ventricular septal defect, B. Perimembranous ventricular septal defect, C. Muscular ventricular septal defect, D. Inlet ventricular septal defect. Correct answer B. Perimembranous ventricular septal defect. Asymmetric VSD closure device has a shorter flange on the aortic side than the apical side to prevent impingement on the aortic valve and the conduction system. The asymmetric device needs only 2 mm of tissue on the aortic rim to hold, while other devices need about 5 mm of tissue all around. Symmetric devices are meant for muscular VSD closure as there is adequate tissue all around to hold the device without impinging on any important structure. If that device is used in the perimembranous location, it can affect function of the aortic valve and the conduction system. What device is seen on this chest X-ray? A. Pacemaker, B. Implantable loop recorder, C. Implantable cardioverter defibrillator, D. None of the above. Correct answer C. Implantable cardioverter defibrillator. Implantable defibrillator high voltage coils on chest X-ray PA view. The ICD generator is seen in the left infraclavicular region. The lead is coursing through the left subclavian vein into the left brachiocephalic vein and hence into the superior vena cava. In this region, the high voltage coil is seen. This ECG is suggestive of A. Wenckebach phenomenon, B. Ashman phenomenon, C. Katz-Wachtel phenomenon, D. None of the above. Correct answer C. Katz-Wachtel phenomenon. The Katz-Wachtel sign is tall diphasic RS complexes at least 50 mm in height in lead V2, V3 or V4, mid-precordial leads. Original description by Katz and Wachtel was published in 1937. The sign has been described in ventricular septal defect with biventricular hypertrophy in children. It can be seen with isolated ventricular septal defect as well as complex ventricular septal defect. In fact, the circulation article cited is on complete transposition of the great vessels. What is the rhythm? A. Sinus bradycardia, B. Idioventricular rhythm, C. Junctional rhythm, D. None of the above. Correct answer C. Junctional rhythm. Regular narrow QRS rhythm at 60 per minute is seen with normal QRS and T waves. P waves are not seen. The first possibility is a junctional rhythm. In a mid-junctional rhythm, the P waves will be within the QRS and not visible. In a high junctional rhythm, the P waves will be inverted in leads 2, 3 and AVF, occurring with a short PR interval. In low junctional rhythm, the P waves are inverted in these same leads but will occur after the QRS with a short RP interval. In mid-junctional and low junctional rhythm, there will be regular cannon waves in the jugular venous pulse as the atrial contraction is during ventricular systole when the AV valves are closed, resulting in backflow of blood from right atrium to the superior vena cava. A slow and regular rhythm with absent P waves can also occur in atrial paralysis due to severe hyperkalemia or due to any other reason. But in this case, hyperkalemia is unlikely as the T waves are quite normal in amplitude. Moreover, the QRS can also become wide in severe hyperkalemia. Atrial standstill can rarely occur as an idiopathic disorder in some muscular dystrophies and following radiofrequency ablation procedures in the right atrium. A third possibility for a slow, regular, narrow QRS rhythm with absent P waves is fine atrial fibrillation with complete heart block. In that situation, the QRS is regular because it is initiated by a junctional focus and not by the irregularly conducted fibrillary waves. It is unlikely that all the 12 leads will not pick up the fibrillary waves in fine atrial fibrillation. In this particular case, this rhythm was transiently seen after conversion of supraventricular tachycardia with intravenous verapamil. Normal sinus rhythm was recorded after some time. Which of the following is not an endothelium-derived relaxing factor? A. Endothelium-derived hyperpolarizing factor. B. Nitric oxide. C. Prostacyclin. D. Thromboxane A2. Correct answer D. Thromboxane A2. Endothelium-derived hyperpolarizing factor, nitric oxide and prostacyclin are the three endothelium-derived relaxing factors. Thromboxane A2 is produced by activated platelets. It is a vasoconstrictor and promotes thrombosis. Patient prosthesis mismatch is most likely to occur with A. Aortic valve replacement, B. Mitral valve replacement, C. Pulmonary valve replacement, D. Tricuspid valve replacement. Correct answer A. Aortic valve replacement. An effective orifice area less than 0.7 square centimeter per square meter of body surface area for the aortic valve is taken as patient prosthesis mismatch in case of aortic valve replacement. This is more likely to occur when the replacement is done in the case of severe aortic stenosis with a small aortic annulus. Rupture of sinus of Valsalva into right-sided cardiac chambers cause left to right shunt. Which is the RSOV with low shunt? A. RSOV into RVOT, B. RSOV into RA, C. RSOV into PA, D. None of the above. Correct answer A. RSOV into RVOT. RSOV into right ventricular outflow tract has lesser shunt as the tract can get obstructed in systole due to contraction of the tract in systole and the shunt is mostly in diastole alone. For the same reason, the murmur in RSOV into RVOT, though continuous, has a characteristic diastolic augmentation. RSOV into right atrium or pulmonary artery have continuous unobstructed flow and hence a large left to right shunt. Liebman-Sachs endocarditis is seen in A. Carcinoid syndrome, B. Systemic lupus erythematosus, C. Hypereosinophilic syndrome, D. Endocardial fibroelastosis. Correct answer B. Systemic lupus erythematosus. Liebman-Sachs endocarditis is a non-infective variety of endocardial involvement seen with SLE. The plaques on walls seen in carcinoid syndrome are called stuck-on plaques because they appear as if stuck on the endocardium of the walls with very little inflammation of adjacent tissue. Endocardial and subendocardial hyperechoic infiltrates can be seen in hypereosinophilic syndrome with Loeffler's endocarditis. ST elevation myocardial infarction is one of the commonest acute coronary syndromes. ST elevation in acute myocardial infarction is known as A. Westermarck sign, B. Paddy's sign, C. Palla's sign, D. Hampton's hump. Correct answer B. Paddy's sign. ST elevation in acute myocardial infarction is known as Paddy's sign. Westermarck sign is focal oligemia of the lung due to pulmonary embolism causing occlusion of a pulmonary artery branch. Palla's sign is a prominent right descending pulmonary artery seen in pulmonary embolism as the vessel dilates due to distal embolism. Hampton's hump is a peripheral wedge-shaped opacity due to pulmonary infarction. Atrial fibrillation is the commonest sustained arrhythmia. In which situation is atrial fibrillation likely to cause ventricular fibrillation? A. When associated with hyperthyroidism, B. When associated with hypothyroidism, C. When associated with WPW syndrome, D. When associated with mitral stenosis. Correct answer C. When associated with WPW syndrome. In Wolff-Parkinson-White syndrome, atrial fibrillation gets conducted to the ventricles both through the normal atrioventricular conduction system and the accessory pathway. The normal AV conduction system has decremental properties and the refractory period increases as the number of impulses reaching it increases. Hence, the normal AV conduction system does not allow too many impulses from the atrium to reach the ventricles. At the same time, accessory pathway refractory period decreases as the rate increases, and it can transmit large number of impulses to the ventricle from the atrium. As the atrial rate is very high in atrial fibrillation, the presence of accessory pathway in WPW syndrome allows large number of atrial impulses to be conducted to the ventricles, leading to fast ventricular response. The rate may become so high that it leads to hemodynamic compromise, and the ventricular rhythm can degenerate into ventricular fibrillation. In all the other conditions listed above, as long as the AV conduction system is intact and there is no accessory pathway, large number of atrial signals are blocked from reaching the ventricle, and there is hardly any chance for ventricular fibrillation with atrial fibrillation. Non-ST elevation acute coronary syndrome with elevation of troponin level is best managed by A. Early coronary angiography and revascularization if feasible. B. Nitroglycerin infusion. C. Thrombolytic therapy with streptokinase. D. Heparin infusion. Correct answer A. Early coronary angiography and revascularization if feasible. And STX is usually due to a non-occlusive coronary thrombus, mostly a platelet plug, which is not amenable to thrombolytic therapy. Thrombolytic therapy is useful in the case of ST elevation myocardial infarction, which is due to an occlusive red thrombus, which is due to blood clot rich in fibrin, and hence the role of fibrinolytics. Nitroglycerin infusion is useful in control of angina in NSTX, but the definitive treatment when troponin is elevated is by coronary revascularization, as troponin elevation indicates a higher risk subset of NSTX. Heparin alone is not sufficient in this setting. Angiotensin converting enzyme is secreted from the lungs, kidneys, and vascular endothelium. Wrong statement about ACE is A. ACE levels are useful in the diagnosis of sarcoidosis. B. ACE inhibitors are important antihypertensive agents. C. ACE converts angiotensinogen to angiotensin 1. D. ACE degrades bradykinin, a potent vasodilator. Correct answer C. ACE converts angiotensinogen to angiotensin 1. Angiotensinogen secreted from the liver is converted to angiotensin 1 by renin secreted by the juxtaglomerular apparatus. Angiotensin 1 is converted to angiotensin 2 from the lungs by ACE. Angiotensin 2 is a potent vasoconstrictor, and hence ACE inhibitors are very useful antihypertensive agents. ACE also degrades bradykinin, and hence ACE inhibition also helps lowering blood pressure by accumulation of bradykinin, which is a potent vasodilator. Accumulation of bradykinin is thought to be the mechanism for ACE inhibitor related cough. ACE levels are increased in sarcoidosis and is used in diagnosis and follow-up of therapy. But it may be worth remembering that ACE levels can also be increased in other conditions like Gaucher's disease and leprosy. Abdominal aortic aneurysm is a life-threatening condition as it has a chance to rupture as the size increases. Non-surgical management of a large abdominal aortic aneurysm is by A. Injection of thrombin into the aneurysm sac. B. Insertion of a stent graft into the aneurysm through the femoral root. C. High-dose atorvastatin. D. Dual antiplatelet therapy. Correct answer B. Insertion of an aortic stent graft. Large abdominal aortic aneurysms are conventionally treated by open surgery with placement of a graft after resecting the aneurysmal segment. But very often, persons with large abdominal aortic aneurysms are in the older age group with associated other severe diseases like significant coronary artery disease, which increase their surgical risk. Hence, more and more cases are now being treated with insertion of a stent graft. Stent graft is a metallic stent with a covering of fabric so that blood does not leak through the stent struts. The folded stent with introducer is taken through a femoral artery cut down and positioned in the aorta so that the upper and lower ends are beyond the aneurysmal segment. When the stent graft is released, it excludes the aneurysmal region and provides a path for blood through the stent lumen. The region of the aneurysm outside the stent gets thrombosed and finally organized. Injection of thrombin by ultrasound guidance is a treatment for femoral pseudoaneurysms. Pseudoaneurysms occurring after an invasive procedure can be dealt with in this manner. High-dose atorvastatin may have a preventive role by reducing atherosclerosis and hence the chance for development of abdominal aortic aneurysm if given well before the development of the aneurysm. Antiplatelet therapy has a role in preventing thrombosis within the stent and not for aneurysm as such. While assessing brachial artery flow-mediated vasodilation, compression to induce ischemia is given: A. Proximal to the site of measurement in the arm, B. Distal to the site of measurement in the forearm, C. Either in the arm or in the forearm, D. None of the above. Correct answer C. Either in the arm or in the forearm. Usually, a segment of brachial artery is measured by ultrasound and proximal occlusion is applied for a period of 5 minutes followed by repeat measurements. Alternative method of induction of distal ischemia, the main vasodilatory stimulus, is by inflating the cuff in the forearm. Commonest great artery relationship in double outlet right ventricle is A. Normally related great arteries, B. Side-by-side aorta and pulmonary artery, C. Aorta is anterior and to the left of pulmonary artery, D. None of the above. Correct answer B. Side-by-side aorta and pulmonary artery. Side-by-side relation of great arteries with aorta to the right of the pulmonary artery is seen in about 2/3 of cases of DORV. Glago phenomenon is A. Positive remodeling of the artery, B. Negative remodeling of the artery, C. Dissection of the intima of the artery, D. None of the above. Correct answer C. Positive remodeling of the artery. Glago phenomenon is the positive remodeling of the arteries described by Seymour Glagow in 1987. Which of the following is an association of patent foramen ovale? A. Chiari network, B. Eustachian valve, C. Atrial septal aneurysm, D. All of the above. Correct answer D. All of the above. What is seen on this chest X-ray? A. Prosthetic aortic valve, B. Prosthetic pulmonary valve, C. Prosthetic mitral valve, D. Prosthetic tricuspid valve. Correct answer C. Prosthetic mitral valve. Prosthetic mitral valve, Starr-Edward prosthesis. Mitral position of the prosthesis is identified by the location below the line joining the left hilum and right cardiophrenic angle. The sewing ring is above and the cage pointing downwards and to the left. There are 4 struts for a mitral Starr-Edward prosthesis, while an aortic prosthesis has only 3. The position of the aortic prosthesis will be above the reference line mentioned above, and the cage will be pointing upwards. A double atrial shadow or shadow in shadow indicating left atrial enlargement is seen along the right heart border. At the same time, left atrial appendage shadow is not prominent on the left border, possibly indicating amputation of the left atrial appendage to reduce chance for clot formation. Sternal wires used for fixing the sternum after sternotomy are also seen. This X-ray is suggestive of A. Multivalvular heart disease, B. Pericardial effusion, C. Epstein's anomaly of tricuspid valve, D. None of the above. Correct answer B. Gross enlargement of cardiac outline due to pericardial effusion. In this case, there was underlying severe right ventricular endomyocardial fibrosis as well. Differential diagnosis of gross enlargement of cardiac size on X-ray include 1. Large pericardial effusion, 2. Epstein's anomaly of tricuspid valve, 3. Multivalvular heart disease, 4. Endomyocardial fibrosis. In large pericardial effusion, the shadow is globular with no lobulations. In valvular heart disease, different bulges in the cardiac contour will be seen due to asymmetric enlargement of various cardiac chambers. In Epstein's anomaly of tricuspid valve and endomyocardial fibrosis, it is mainly right atrial enlargement, including atrialized portion of right ventricle in Epstein's anomaly. Which of the following tests can be used for detection of right to left shunt across patent foramen veil? A. Saline contrast echocardiography. B. Transcranial Doppler. C. Ear oximetry. D. All of the above. Correct answer D. All of the above. Saline contrast echocardiography using agitated saline is to detect right to left shunting across PFO. Transcranial Doppler can be used to detect microbubbles in the middle cerebral artery after injection of agitated saline into the peripheral vein. Ear oximetry can detect fluctuations in oxygen saturation due to right to left shunt across the PFO. Which of the following is not a diagnostic test for carcinoid syndrome? A. 24-hour urine 5-HIAA. B. 24-hour urine VMA. C. Chromogranin A. D. Indium 111 penditriotide scanning. Correct answer B. 24-hour urine VMA. Urine VMA estimation is done for the diagnosis of pheochromocytomas. 5-HIAA and chromogranin A are used for the diagnosis of carcinoid syndrome, while 111 indium penditriotide scanning is used in locating the tumor as well. Carcinoid syndrome is characterized by episodic flushes, abdominal pain, and diarrhea due to a serotonin secreting carcinoid tumor. Wrong statement about carcinoid syndrome. A. 5-hydroxy-indole acetic acid level in urine is elevated. B. Left-sided heart valves are commonly involved. C. Octreotide labeled scan is useful in diagnosis. D. Indicates hepatic metastasis. Correct answer C. Left-sided heart valves are commonly involved. 5-HIAA is a metabolite of serotonin and is detected in increased quantity in urine in those with carcinoid syndrome and hence can be used as a diagnostic lab test. Intestinal carcinoid tumor without metastasis is unlikely to manifest the carcinoid syndrome as the liver acts as a filter and the serotonin produced by the tumor has no chance of affecting the heart valves. Presence of hepatic metastasis help the increased serotonin levels to act on the right-sided cardiac valves. Left-sided valve involvement generally indicates additional lung metastasis as lung acts as the second filter, removing serotonin further from the circulation. Octreotide, a somatostatin analog, can be labeled with indium 111 and used for imaging neuroendocrine tumors which express somatostatin receptors. It is also useful for treating diarrhea and flushing associated with carcinoid syndrome. Normally, QRS complex is predominantly positive in lead 1. A predominantly negative QRS complex in lead 1 can be seen in all of the following except A. Dextrocardia, B. Left bundle branch block, C. Arm lead inversion, D. Severe pulmonary hypertension. Correct answer B. Left bundle branch block. Left bundle branch block is characterized by a notched R wave in lead 1, which is dominantly positive QRS deflection. In dextrocardia, since the activation of the ventricles is opposite to that of levocardia, the QRS complex is negative in lead 1. Same pattern occurs when the left arm and right arm leads are reversed. Arm lead reversal can be identified by absence of change in chest lead pattern corresponding to dextrocardia. In normal persons, chest leads show a progressive increase in positive deflections from lead V1 to V5 or V6. This progression does not occur in dextrocardia as the predominant ventricular mass is on the opposite side and not beneath the standard chest leads. In severe pulmonary hypertension, there is right axis deviation and the QRS complex becomes dominantly negative in lead 1. Bispherian pulse may be seen in all of the following except A. Free aortic regurgitation, B. Combination of aortic regurgitation and stenosis, C. Hypertrophic obstructive cardiomyopathy, D. Phallostetrology. Correct answer D. Phallostetrology. Bispherians pulse has two systolic peaks and is seen in both free aortic regurgitation and a combination of aortic regurgitation and stenosis, especially when the regurgitation is dominant. In severe aortic stenosis, the pulse is low volume and slow peaking. Pulsus parvus a tardus. In hypertrophic obstructive cardiomyopathy, soon after the initial rapid ejection of blood into the aorta, the dynamic left ventricular outflow tract obstruction comes into play and reduces the volume of pulse, followed by a delayed additional peak of lesser amplitude, giving a Bispherians nature. The pulse in HOCM is most often felt as a jerky pulse rather than as a true Bispherians pulse. Hypertrophic non-obstructive cardiomyopathy does not cause a Bispherians pulse. In phallostetrology, a high volume pulse can be felt because outputs from left ventricle and part of the right ventricular output by the right-left shunting across the ventricular defect reach the aorta. Only a small portion of the right ventricular output reaches the pulmonary artery due to the obstruction of right ventricular outflow tract. Dual peaking Bispherians pulse is not a feature of tetralogy of Fallot. This chest X-ray PA view shows A. Prominent main pulmonary artery segment, B. Prominent left atrial appendage, C. Prominent descending aorta, D. None of the above. Correct answer A. Prominent main pulmonary artery segment. The region just above the bulge on the uppermost part of the left cardiac border is the aortic knuckle. The prominent bulge is due to the main pulmonary artery segment, usually indicating severe pulmonary hypertension. Right pulmonary artery is also seen dilated just lateral to the right cardiac border. The region below the prominent main pulmonary artery segment corresponds to the left atrial appendage. Which of the following can be used for aiding smoking cessation? A. Bupropion, B. Nicotine, C. Varenicline, D. All of the above. Correct answer D. All of the above. Nicotine replacement therapy can be used in various ways like nicotine gum, patches, lozenges, inhaler, and nasal spray. In fact, nicotine replacement therapies have been given over-the-counter access, but bupropion and varenicline are prescription drugs used in smoking cessation programs. Shortest acting P2Y12 receptor inhibitor: A. Prasugrel, B. Clopidogrel, C. Cangrelor, D. Ticagrelor. Correct answer C. Cangrelor. All these drugs are P2Y12 receptor inhibitors. The first two are irreversible inhibitors, while the latter are reversible inhibitors. Cangrelor is short-acting, so that it has to be given as an infusion. Regarding risk of venous thrombosis in men versus women, true statement is A. Risk of venous thrombosis is almost equal in men and women, and second venous thrombosis higher in men. B. Risk of both first and second venous thrombosis is higher in men. C. Risk of both first and second venous thrombosis is higher in women. D. None of the above. Correct answer A. Risk of first venous thrombosis is almost equal in men and women, and second venous thrombosis higher in men. A study has shown that even the risk of first venous thrombosis was twice as high in men compared to women if you exclude the risk due to reproductive factors like use of oral contraceptives, pregnancy, puerperium, and hormone replacement therapy.